Today on the Diabetes Podcast.
When stress hormones become chronic, those signals can contribute to higher glucose and worsening insulin resistance.
Diabetes thrives when your attention is elsewhere.
Diabetes remission is not the same as diabetes permanently cured.
Hello and welcome to the Diabetes Podcast. I'm Richie.
And I'm Amber.
And Amber, today we are talking about, for many people, the road to remission, or at least the road to healing, is not necessarily a straight line. Sometimes there's some ups and downs.
Yep.
And we're talking today about what happens when someone has maybe some unexpected negative outcomes on the road to remission. How does one get back on the wagon after a setback?
Mm-hmm. Yeah, and I wanted to start by saying that oftentimes people will say, I know what I'm supposed to do. That's such a common phrase for someone in my role to hear. And there's this disconnect between what I'm quote unquote supposed to. Anybody who knows me knows my disdain for supposed to, that phrase together. And then you have others in healthcare that don't really understand, if you know what you're supposed to do, then why aren't you doing it? And those things are really very different questions. And knowing what to do and having the capacity to do it are very, very different things. And if you think about your own life, you can know that you need 8 hours of sleep while you're lying awake at 2 o'clock in the morning, worrying about something that you really can't do anything about at 2 o'clock in the morning yet. There you are. And you know you need to go to sleep, yet you're worrying about having to pay the mortgage, or did I remember to do this? And you know that exercise would help you while you're working 12-hour days and taking care of an aging parent. You can know exactly what you would make for dinner and still pull through a drive-through on the way back from, when I think about when we really had that drive-through era was when Judah was in baseball all the time. And I mean, when you get back at 9:30 at night and the kids have school the next day, there's no making dinner at that time. So you're just emotionally and physically spent sometimes, and it's hard to do the I know what I should do kind of things. So that's not a nutrition knowledge problem or knowledge of what to do. It is a capacity problem. And interestingly, the American Diabetes Association specifically recognizes this. The 2026 Standards of Care direct clinicians to consider environmental, social, family, behavioral, emotional, and financial circumstances when someone's diabetes management is deteriorating.
So that is probably, while excellent advice, I think. Mm-hmm. How do clinicians do that in the 15, like you just gave them at least 6 more metrics that they don't have time to get into in the already limited amount of time that they have, face time that they have with their patients?
Yeah, it's not without challenge. And usually good clinicians will do this. And sometimes that means you only tackle one thing at a time. Today, it's the 2,100 deductible. That means you're not taking your insulin prescription in January and February. And so then how does the provider ensure that the person has their insulin the first 2 or 3 months out of the year? Or it's just, I see this all the time where people stretch their medications until they've met some sort of deductible. And that's a whole conversation in terms of insurance and coverage. But I think it's important to understand what somebody's home life looks like, what they're up against when you're also asking them to take care of a very complicated disease state. So I like that the American Diabetes Association has put this in the forefront, but it's also a little bit like lip service in that that's beautiful in theory, but how exactly do you do that? And where's the social work in the primary care office? And where's the social worker in the endocrine office? Where's the manager of all of these things? And a really great, and we've talked about this before, a really great diabetes center would have a certified diabetes care and education specialist, a pharmacist, a nurse, a dietitian, would have a combination of those things, and hopefully several of those, but it's quite rare to have something like that. I think maybe Joslin Diabetes Center, a couple of other centers across the nation, but not that many have that inclusive of a care team. And a lot of that has to do with cost. It all comes down to the mighty dollar in the end, which is a sad but true state of affairs. So back to the standards of care, they specifically recommend assessing things like stress, finances, available support, and major changes in life circumstances. That matters because oftentimes, especially in more academic hospitals I've seen, people are treated like it's in a lab with all these controlled things. Like you just do A plus B equals C, because they're not considering variable X, Y, or Z, or this exponential factor coming into play over here. And there's just so much going on. It's not just eat this, exercise this amount, take this medicine, check this. You don't live that way. You live in a family structure, family dynamic, and in this social construct, and you have relationships, a job, bills. People disappoint you. People need you. You get sick. You get tired, especially if your blood sugars are high. You get tired. And sometimes one or all of those things are happening all at once, and your physiology is experiencing all of it with you. So then you have what I really start to wonder, because stress gets talked about a lot and we talk about cortisol as if cortisol is some horrible hormone that we need to eliminate, but cortisol isn't bad. Your stress response is quite remarkable. Imagine you're walking through the woods and suddenly there's a mama bear there thinks that you're after her cubs. Your body doesn't say, let's carefully assess these long-term metabolic goals. That is not.
Let's focus on my breathing exercises.
Yes. Your sympathetic nervous system turns on, adrenaline rises, cortisol rises, your heart beats out of your chest, blood flow gets redirected, and your liver starts dumping glucose and to make that sugar available so you can flight if that's your decision. I'm not fighting the bear. I'm going to fly. So because glucose is your fuel, your body is essentially saying, we've got a fuel emergency going on. Energy needs to be available right now. And so your liver breaks down stored glycogen and releases glucose into your bloodstream. And adrenaline and cortisol help keep that fuel available. Insulin sensitivity can temporarily decrease so the glucose stays in circulation where it's needed. And all of this helps you survive the bear. Brilliant physiology. But the problem is when the bear, as it were, does not leave our system, when the bear becomes your business, your work, your relationship, your finances, or caring for someone that you love, losing your home, sleeping 5 hours every night for 6 weeks or 6 months. Your body doesn't understand the story. It understands the signals that your physiology is putting out. And when stress hormones become chronic, those signals can contribute to higher glucose and worsening insulin resistance. So that doesn't mean stress caused my diabetes. Not necessarily, because you just don't live in a bubble like that. And there's so many other things going on.
I think in the recommendations, I think it highlights that when we talk about the environment, there's a lot of things that go into that environment, right? So your stress is a reaction to many different things in your environment, and potentially even we've talked about with our clients, negative thought patterns, how to kind of just a shift in perspective can often change that stress response to any given situation. So not just the external environmental factors, but also the internal and some self-inflicted internal environmental factors as well. All of that's the environment. All of that is shaping how bad and how fast this disease is going to progress, or the other way around if you're changing your environment.
Yeah, and I think the bottom line with all that is that type 2 diabetes is very complicated, and genetics do matter, but your beta cell function matters, your fat distribution matters, and that's really a big way in which genetics can come into play, is where historically your family stores body fat. Physical activity matters. I believe that nutrition matters, sleep matters, medication matters, age matters. There's so many things that interact, but chronic stress can become one contributor, like a huge lever within all of those things in the system. And then stress can change behavior as well, because if you're sleeping less, moving less, food becomes more convenient. Speaking to everything you just said about the environment, you could be taking your medication less consistently, even if it's a financial stress and your copay for a certain medicine is unaffordable. Someone that I talked to very recently, today, in fact, has not seen their provider because they don't have insurance right now. And that's very common, especially if in type 1 diabetes, pediatric care, younger individuals who then went off to college or turned 21 and got off of their parents' insurance are in this space before they get a job that has benefits where they're uninsured. And it's a very scary place, especially for someone who has type 1 diabetes to be. And then oftentimes with people who have type 2 diabetes with Medicare, many people don't understand that they need that prescription drug plan. And so they only have A and B, and they don't have that supplemental drug plan. And that's not without cost. It's going to be $2,100 every year with that Part D plan. Most people there's that word, that Part D plan, but some people don't. And some of them are using their older insurance, but then once you get on Medicare, it behaves completely differently. And people who had great insurance while they were working then get on Medicare and their insurance completely changes. And it's something they weren't really budgeting for. There's a lot of things with insurance. I think we should probably do a whole, I feel like it would be such a depressing episode, such a needed episode.
We're going to talk about things we have no control over for the better part of an hour.
Yeah, that's probably why we haven't done it yet. But it is important still.
We'll get some representatives on here at some point in time and start asking them some questions about.
Representatives from where? I don't think we're going to get a United Healthcare executive up in here. That's not going to happen. Anyway, back to the complicated life and all of the things going on. If you're having to care for an older parent or having to do these other things, or you had some circumstances where you're working too much and all these things come in, oftentimes people will stop checking their blood sugar. And where I see this happen the most is when people check their blood sugar and it's a high number and they know it's high, and they're just doing what their doctor said, or they ran out of the meds, couldn't afford the copay to take the meds for what their doctor said. And essentially there's this sort of cycle of hopelessness that can occur where they're like, it's just going to be high. So why am I going to check it? Why bother? It's just going to be disappointing. So why am I going to poke my finger? That hurts and be disappointed. And I completely, I've heard so many people say this to me, And I completely understand, because why would you just, oh, that's depressing. Oh, that's depressing. Let me just continue doing the same thing and expect something different on this meter, you know? And then people will often miss their appointments because they might feel like they're going to be disciplined at these appointments, even though I don't believe that the physicians are like, oh, who can I berate today? That's not what happens. It's maybe they don't understand the consequences of this. So if I really hammer home what this can do and what I see happen to people, then maybe that will inspire them to change behavior. But most of the time, it doesn't. It just doesn't. Something doesn't really connect, because I think of it like if we try to tell our teenagers how bad something could be, it's not the same as them experiencing it themselves. You know, like you have to have this lived experience to really understand. And I'm not saying that people with type 2 don't have lived experience. I'm saying they don't have the 360-degree view of the entire process.
But what you're saying really is why pre-diabetes will ultimately become type 2 diabetes in most situations, because that lived experience, like the reality is pre-diabetes isn't that bad. You might not feel as good as you did in your 20s and 30s, but that's kind of is an expectation for most people, right? So upon a diagnosis of like pre-diabetes, that really doesn't mean anything other than you just told me my blood sugar was something, but I can't tell you the difference between what a 6 and what a 5.6 feels like. Maybe not even a 7, right? It's not a tangible thing that's going to elicit any kind of change versus, you know, you don't need to go into DKA more than once to probably realize that, oh, it's bad now. That kind of thing. I didn't know that I could just wake up in the hospital. That's a new thing that kind of illustrates how serious this disease is if you ignore it.
That can happen. So let's just say your glucose starts rising. To your point, initially you don't feel any different. And that's really one of the first frustrating things about diabetes, is that a glucose of 180 doesn't necessarily hurt at all. You don't really feel any differently. Same with 220. So you can live with an increasingly high glucose for quite a while without your body screaming at you to do something about it. Meanwhile, though, underneath the surface, your metabolic environment is changing. And we've had many prior episodes where we talk about all the ways in which your body is changing from the insulin resistance. And your muscles don't respond as effectively to insulin. So your liver may keep releasing glucose when it should not. So this inappropriate release of glucose, when the job of insulin would normally be to tell it to slow down and stop releasing that glucose. The pancreatic beta cells have to work harder to produce enough insulin to compensate. And prolonged high blood sugar itself can further impair that beta cell function and insulin sensitivity. So we've talked before all of these things. So now imagine that is happening in your life where the sugars are rising and you're starting to feel exhausted. And usually by that time, the glucose might be around 250 if you were to do a whole blood finger stick test. Urinating more, thirsty, sleeping poorly because you're getting up to use the bathroom, dehydrated, feeling sluggish. Maybe the vision's a little blurry, maybe not. And all of these things you could also attribute to, oh, I'm just starting to get more farsighted in older age. Maybe this is just what aging looks like. Most of the time, that's where the credit is given. And the standard advice for that is exercise more, but you feel terrible and don't have the energy to exercise more, so you move less. And this is where I want you to see where I'm trying to get to here, is that the behaviors that could help are the exact behaviors that you don't want to do because of how you feel and because of the energy level that you have. It's just harder to do these things because of the physiology that those behaviors are creating in your body. Your activity would improve this. However, it's that avalanche effect that we've talked about before, because now we've got that feedback loop going on, and life can become overwhelming if you allow it to extrapolate to like all of life. Everything is this way now. And if your diabetes care deteriorates, the glucose can rise, the high blood sugar makes you feel worse. Feeling worse makes self-care harder. Self-care deteriorates further than the glucose. You get the point. And eventually it stops becoming a situation where the appropriate response is, I just need to get back on track and pull myself up by the bootstraps. And it could become like, I genuinely need medical help, because at this point, it's beyond me. It has gotten away from what I'm capable of in this moment because of life circumstances.
So to kind of bring it back to what we're specifically talking about is not just how to get better, but how to get back on getting better. Once you've seen some positive movement, once you've seen some numbers start to move in the right direction and whatever happens. As we're saying this, what comes to mind is that diabetes thrives when your attention is elsewhere. Like we've talked what things that diabetes hates, things that diabetes likes.
Yeah.
Diabetes hates attention, right? If you're checking your blood sugar regularly, whether it's good or not, you're aware of what's going on, versus I was good last week, that kind of mindset without checking on it. Diabetes thrives in an environment where you're just busy. It's not a good or bad thing. I've got other things to do than to check on my blood sugar. I've got other things to do than to know what's going on inside my body
and isn't
at
that,
any given time.
Yeah, and isn't that just a metaphor for most things, that the bad things thrive in the darkness, that when you shine a light on it, there cannot be darkness there because you've shown a light onto that and you've exposed what's happening.
But I think it's also just an awareness that this thing will absolutely get worse if you're not paying attention to it forever. Even if you've done all the right things, even if you have really, really drilled down on the behaviors, you've titrated down your medication or maybe eliminated your medication altogether, you're never going to not have to pay attention to this. You may pay less attention to it, but
yeah, I think
there's never, it's not just gone.
You're never done. It's not, okay, I can put this to rest now, it's all done, because it requires constant vigilance. So let's talk about when your blood sugar is 350 and above.
Okay.
So imagine you check your glucose and check it again. Maybe you're thinking, okay, I need to stop eating carbs, drink a bunch of water, go for a long walk. I'll get serious tomorrow, or I'll get insurance tomorrow. That's a harder, more realistic one, And that's where your determination, or I just can't do it right now. And that's the hard part, because sometimes when you can't, you can't. And sometimes when you think you can't, it's more about reorganizing priorities. And there's no shame or blame in any of this. It's just, you have to be careful, because a blood glucose of 350 or 375 doesn't automatically mean that You have, as you mentioned before, DKA, which is diabetic ketoacidosis, but also it should not just be dismissed as something that, oh, just happened. Because I really want people with type 2 to understand this, because there's a misconception that diabetic ketoacidosis only happens in people with type 1 diabetes. And it doesn't. People with type 2 diabetes can develop diabetic ketoacidosis. And even more likely, though, is that there's another high blood sugar hyperglycemic emergency called hyperosmotic hyperglycemic state, or HHS, which occurs predominantly in people with type 2 diabetes. So talk about the difference for a second. You have DKA, diabetic ketoacidosis. So there are three pieces that come together with that. There's the diabetes hyperglycemia, which is just high blood sugars. There's significant ketone production, which are these acidotic kind of fat bodies. And then there's metabolic acidosis, where the blood becomes too acidic. And that's where you get that acetone breath, trying to breathe off some of those ketones to get rid of some of the acid in the blood. And so there's a whole cascade of things that occur there. And the 2024 consensus criteria require all three, which means the glucose number by itself doesn't diagnose diabetic ketoacidosis, but the ketones in the blood chemistry do. And that's why someone already known to have diabetes can develop DKA at a glucose below 200, more specifically if they're on an SGLT2 inhibitor, like Farxiga, Jardiance, used to be Invokana as well. It's called euglycemic, where the blood sugar number is not as high as one would normally see DKA, euglycemic DKA. And the diabetes part of the diagnosis is met by the history, not the glucose in that day. Like, oh, you're that high and you're feeling like you've got to throw up and you're feeling nauseous and your blood sugar's 200 and you've been sick and you're on an SGLT2 inhibitor. Like all those factors come together. It could be very well DKA. And so let's test other markers. So a 375 blood sugar doesn't prove diabetic ketoacidosis, and glucose below 250 doesn't automatically rule it out either. That's why symptoms and appropriate testing matter. And then there's the HHS, the hyperglycemic hyperosmolar state. This is where if there's an elderly person admitted to the hospital who is not someone with type 1 diabetes, this is what they would most likely be diagnosed with high blood sugar. And it's different because the glucose can become extremely high, like well over a 600 blood sugar. And someone that we know recently went into the ER with a blood sugar over 600. And at this stage, profound dehydration develops without the degree of ketoacidosis that you would see in DKA. And these conditions can overlap. In fact, the 2024 consensus report notes that overlap between DKA and HHS occur in more than a third of hyperglycemic crises. So 1 in 3 of everybody that goes into the hospital and is diagnosed with DKA or HHS probably has some overlap between the two. And that's not, like, it doesn't matter if it's DKA or HHS. That's nothing that you can diagnose at home and have just one glucose number and say, oh, I have this. So if you're experiencing very high glucose alongside things like significant vomiting, abdominal pain, rapid or deep breathing, confusion, profound weakness or dehydration, an inability to keep fluids down, or significant ketones, that needs urgent medical attention. And so I want to speak to people like our friend that at least thankfully went to the ER, but really to the people that are like, I can handle this alone. I can take care of this. when it comes to DKA or HHS, there is no prize for waiting. Getting evaluated doesn't mean you've failed to manage your diabetes, which I can absolutely see how it could feel that way, because that's often a question if you go see your endocrinologist, or if you, especially if they're looking at being a candidate for an insulin pump. Have you been diagnosed with diabetic ketoacidosis in the past 6 months? That's a question that's almost always on the forms, or something that you would ask. But if you get evaluated, it means you're really listening to your body and you're responding to what's going on. So it can be deadly. You can go into a coma. It's very important that you seek medical help and get it before it gets too far gone, too acidotic, too much, because then the body shuts down to try to fix it. So now we get into what I consider a harder part of this conversation, because some people might be listening and say, Amber, I understand all of this. I already did this, lost the weight, changed how I ate, exercised, got off the medicine. A1C was 5 point something. I had it under control. And now you're back here, and I can understand how that could feel devastating. But I would really like to discuss or dive into, or maybe change the way that person is interpreting what's happening. Because diabetes remission is not the same as diabetes permanently cured, which is why oftentimes in anything that we put out or talk about, we are very specific in the terminology diabetes remission and not reversal, which is the key word. And I think maybe in one or two marketing of all the hundreds of marketing things we've done, we might have used reversal only to lure you in. And then we say, hey, it's remission. Because as to your point of what you said before, it's never goodbye. Think of it like the tortoise and the hare. You could fly away from that turtle, leave that turtle miles behind. But if you go nap under the tree, that turtle could catch up to you. You can never take a nap.
I'll take you one even better. I've seen any number of cleaning ads lately where they talk about this cleans or eliminates up to 99.9% of bacteria or whatever that thing is. The dental commercials are actually doing better. When they show the rinse go through there, it takes all the gunk, but there's always one little tiny little green speck. That's that 0.01% or whatever that is.
We got to leave the 0.1%.
It's kind of the same deal. When we talked about the environment shaping diabetes, you can, there's some environmental factors that you do have control over. There's some environmental factors that you can change. And when you start doing that, typically the numbers come down. Those numbers start to look better. And over time, they start to look really better. And the symptoms start to get better and all this other kind of stuff. But again, it's like I can clean the house top to bottom. It's going to be a mess next week unless I do some cleaning this week.
Yeah, so why even bother cleaning?
There's always going to be some kind of baseline cleaning. The same thing relates to your health. If I have to do something, not even every week, almost every day. I have to do something almost every day that diabetes hates, whether that's moving some or putting food in my mouth that does not encourage my blood sugar to go up, that kind of stuff. I'm going to have to make good choices almost daily for the rest of my life.
Yeah,
I'm not saying that you make bad choices, you're a bad person. I'm not saying any of that kind of stuff. Again, it's that attention bit. I'm choosing to eat this because I know diabetes hates this. I'm choosing to walk. Maybe the only reason I walk that day is not because it makes me feel good. It's because diabetes hates when I walk after meals. That kind of stuff. It is that shift in mindset of no matter what I have going on in life, diabetes never lacks for motivation. Diabetes never takes a day off. Diabetes never will not try to really entrench itself as much as possible to make the rest of your life as miserable as humanly possible. It's just way more consistent than I am, unless I choose to out consistent it.
Out consistent it. Yeah, I think the
that's
word. Sure. They're all words that you put together there. That's for sure. So the word remission actually acknowledges something very important, and it's that high blood sugar can return. The consensus, the international expert consensus, chose the word remission. The 2021 consensus defines remission as an A1C below 6.5 for at least 3 months without glucose lowering medication. They could have said reversal. Mm-hmm. They could have said get rid of it. They chose the word remission to acknowledge that if someone regains weight, an illness comes along, stress, anything that would cause a decline in beta cell function could be a possible contributor to recurrence, which is why people in remission still need that. To your point, that's why that diligence is still needed. So if your diabetes came back, if you were successful at being in remission for 5 years, 6 years, you haven't taken medication, it doesn't mean that it especially does not mean that you are a failure, nor does it mean that you have failed or that your remission was fake. Those years mattered because every year you spent with lower glucose helped prevent long-term complications from type 2 diabetes. So every walk mattered. Every improvement in insulin sensitivity mattered. Every pound that you lost that improved the metabolic health as a result mattered. So whatever benefit occurred during that time doesn't just disappear from history because your A1C increased again or your blood sugar increased again. And your recurrence doesn't retroactively turn your success now into a failure, because remission is not a character test, nor is recurrence. And they're just descriptions of physiology. It's just what's going on. Your physiology changed once and it changed again. And now we're going to respond to what it's doing today. And I think you'll see these common threads come up in successful entrepreneurs. You see people, Michael Jordan is a fantastic example. You see people who have failed, who come back and are wildly successful. So if you failed and didn't learn anything, that's a failure. That would be a true failure in my mind. But if you failed and learned and know, like someone who has achieved successful remission in the past, I'm not a betting person, but I'm going to place my bets on that person to be successful at remission again before I'm going to place my bets on someone who's never taken those big, bold leaps to take that action in the first place to achieve remission in the first place. So
to speak just to the activity bit, if strength training was a part of your solution to putting diabetes in remission in the first place, that muscle memory is a real thing. You change the composition of your muscle tissue, which is why it's easier to get back to. So take that for what it is. If you've done it once, you can probably do it again, and you can probably do it faster than you did the first time, at least as it relates specifically to that strength training component.
Yeah. All right. So here's the point where I might lose some people.
Got to do what I got to do, son.
Got to do it. Because I know what many people want. They want off medication. People told me that for years. Anybody that's working towards remission, they're working towards not being on medicine. That's one of the biggest things that they say. I don't want to be on medicine. Hate taking pills. I don't want shots. Every time I go to the doctor, they just add more medicine. I don't even know what they're doing. They just keep adding medicine. They don't care about me, which is like the interpretation of they just keep adding medicine. I want to fix the actual problem. And that's where you have this whole industry of holistic medicine, talking about root cause, because they know that where there is a need, they will happily step in with supplements, potions, snake oils to fill that gap. But if it doesn't really improve anything, you're not filling anything but their pockets. So I know that people say these things. I know that that is the desire. That's what people want. I understand that. And I still believe that improving the physiology, that underlying physiology, matters a lot.
Is it safe to say that, again, intentionally leveraging the behaviors that reduce A1C, that reduce blood sugar, can no matter where you're at on the diabetes spectrum, reduce the volume of medication that you need? Because again, that medication is almost, and I think this is probably where a lot of the miscommunication comes in the first place, is that the medication is always going to be that support structure. It can never do all of the things by itself. Mm-hmm. It does not have that capacity to do that. So doing the behaviors will, and correct me if I'm wrong, reduce the requirement for at least as much medication. And I think if you're approaching your physician from the standpoint of, I want to take as little medicine as humanly possible and not negatively affect my health. Well,
I think okay. The medication is a tool,
right?
Not a goal. You use the tool to get to the goal. The goal is blood sugar control. That
if you give me a second.
Okay.
If you are approaching your physician from the I want to take less meds and you want me to have controlled blood sugar.
Yes.
Right?
Thank you. That's
I think we can work together, and I think your physician needs to understand that that's what you want. That's what's important to you. And hey, doc, if every time that I see you, my A1C is moving in the right direction, my blood sugars are moving in the right direction, maybe even my body composition, if you're doing that kind of stuff, is moving in the right direction. If I'm consistently showing progress, is it not realistic that over time we can start titrating the volume of medication down, or maybe can we get? But I don't think people are having that conversation. It's not fair. They're not talking about how do I wean myself off of this, and in response to measurable and repeatable positive movement in the right direction from an A1C and a blood sugar standpoint.
And I think that we're conflating two things, because we've talked about diabetes remission and going in the direction of getting off of meds and how to do that. Now we're talking about when people have slip ups and they're going in the wrong direction. If you're going where your blood sugars are higher, you might need to add medication that you had previously been able to come off of because of what you're talking about there. So this is, if you are slipping and going in the other direction, you might need the scaffolding again, because the goal is blood sugar control. The goal is using that as a tool to be able to get to the gym, to be able to have enough energy to protect yourself from hospitalization for heart failure, which a lot of the SGLT2s and also some of the GLP-1s can do. So it is thinking of them as a tool, not these evil things that I must come off of at all costs.
I think
I know you weren't saying that, but I just want to be clear, because I know your intention of how you're saying that, but I don't know that everyone does. I think our listeners that listen all the time do, but if this is your very first podcast, I just don't want to conflate those two ideas.
Fair enough. The only way the medication's ever going to come down, whether this is your first time or your second go round or your third or fourth, whatever that is, you're going to have to lean on the behaviors increasingly more, because that's the only thing that's going to ever allow you to reduce the medication.
Agreed. I don't think we were ever in disagreement about that.
Okay. That's all I was saying is most of the time when we see these kind of hiccups, when we see these kind of setbacks, it's because some other stuff happened, not related to diabetes. Any number of life events, something changed. It could be my job changed. It could be a death in the family. It could be any number of different big, important life changes that caused you to not prioritize those behaviors as much as you did. And then if you do that long enough, it's right back. That's all I'm saying.
Exactly. Reducing medication can be a very reasonable future goal. But sometimes medication is the tool that helps make it safe enough for you to work towards that goal, because you can't work towards that goal with your sugars in the 300s. And if your glucose is severely elevated to the point where you need insulin, needing insulin today does not cancel your desire or need to have less insulin tomorrow. There's nothing about going on insulin today that says you're going to have to be on this for the rest of your life. Now, full disclosure, there was a point in my life before research advanced 18 years ago, 17 years ago, where it was believed that when you were diagnosed, you'd already lost half of your functioning beta cells. So if you ever got to the point where you needed insulin, you pretty much, your beta cells were done. And so you needed insulin, and you probably would require insulin for the rest of your life. So I have told people before, if you're that 1 to 3 people that I've ever told that to, I apologize. And if you're listening now and you're like, she told me that, then I'm glad you're here listening. I doubt that you're here listening, because it was like a very small percentage of anybody I've ever talked to. But I have said that before. Yeah. And I think probably many healthcare providers have said that before to people. And so there's this fear that if I go on this, then that's it for the rest of my life. I'm on this. And we know several someones who were on a lot of insulin, required no insulin, and some of them required insulin at some point due to steroids or due to some other thing going on in their life. And it doesn't mean that they can never come off ever again, except if there is an autoimmune component that could mean that you have to have insulin for the rest of your life. So sometimes insulin is exactly what your body needs right now. Sometimes glucose needs to come down. It just needs to come the flip down. It's too high. And sometimes dehydration needs to be corrected. Sometimes beta cells need relief from that enormous secretory burden. And sometimes getting glucose under control is what helps you feel well enough to begin to do the other things that you need to do in your life again. And insulin is not a personal failure. It's a treatment tool, just like your SGLT2s, your GLP-1s, your sulfonylureas, your biguanides, any of those. And then we keep working. To your point, just because you take it, don't be like, now I can go eat all the cookies and the cake because I am taking insulin now. And I understand why people do that, because it's been like decades of restriction. And now you have this tool that you can eat whatever, and it gets the glucose into the cell. And so there's some freedom that comes along with that. So I completely understand it, and would not shame anyone when they first go on insulin if there's this little binge that comes in for a little while. But you do need to rein that in after maybe that initial, okay, this is getting out of hand. Let's reel it back in. And then another part of all of this, in terms of someone who had good control of their blood sugar and then ended up slipping again, is that sometimes people disappear off the radar of healthcare. They stop going to appointments. They don't return calls. Friends reach out, family members text, healthcare providers call, and they don't respond. And I've thought a lot about why, like why people are trying to help you. Why are you not responding? And I can't tell you why that person's not responding. That's the answer that I got out of all that, is I don't know. And I think only that individual can tell you what's going on, because unless they come to you and say, I just didn't want to feel like I'd failed again, or I didn't, unless they tell you why that was occurring and why they didn't show up, you can't put words or feelings into their mouths.
Well, I imagine it's incredibly disappointing. That's
at the very least.
Every person that we've worked with that has successfully put this thing into remission are not quiet about it. It's very much look at this amazing thing that I was able to do.
And then
how
you
awesome
want to
this
help
is.
other people.
Yeah.
Guess how this is how I did it, and you shout it from the rooftop. So then they're the success story to everyone that they know. And so then what happens when the success story is in the moment? Because I don't believe until you're dead, your success story can still be written. Yeah. I don't, it's a minor setback. And in the minor setbacks, it's hard to yell from the mountaintops, I'm in a setback right now, but I'm coming, like it's hard in that moment to be very vocal and show up all the time, because oftentimes it's just sheer exhaustion. I think that's probably, if I had to say one thing I've noticed the most and what people have shared with me the most, it's exhaustion. It's just, it's exhaustion coupled with, if I ignore it, it'll go away, which is completely untrue. But I understand it nonetheless. And it could be fear of going back on insulin. And so that is diabetes distress. That is what the American Diabetes Association and all the consensus statements, that's what they're talking about, is a very well-known, well-documented diabetes burden and diabetes distress. And it's not the same thing as depression. It's the emotional burden of living with a disease that asks something of you every single day, relentlessly. Check this, take this, don't forget that. Think about dinner, think about exercise. How many carbs are in that? Think about your feet, schedule your eye exam, pick up the prescription, call insurance. Oh, wait, the prescription's not here, but I told the doctor the prescription's over there. Oh, we sent it there. Let's transfer it here and send it over here. Oh, we're going on vacation. Do I have all my supplies? Look at the glucose, correct the glucose. Think about tomorrow. Am I planning for that? Do I have my lunch packed? It's just, it's exhausting just to go over that list. And that's not even a tiny fraction of the actual list of what people deal with, because diabetes never clocks out. Yeah. You're never on vacation from that. And the American Diabetes Association now recommends screening for diabetes distress at least annually. And again, when the treatment goals aren't being met, or complications occur, or someone is going through a life transition. But you don't call your doctor and say, hey, my parents are now not able to take care, or my mom is having to take care of my dad, and now I'm stepping in so that my mom gets some relief. Or no one's calling their doctor being like, is there a diabetes distress test that I can take? And what are you going to do? Like, what?
It's positive.
Yeah. And I think often, and this is the sad part, is where I think often this disengagement, because it all feels like too much, it gets considered as or diagnosed as someone doesn't care, or that ever-present word, and I'm ashamed that I've used it before, many years ago, through sheer ignorance, that non-compliant statement. And I think the longer that I work in diabetes, the more I understand that I don't know that I have ever met somebody with diabetes who is truly non-compliant. I think I've met people who are truly overwhelmed. I've met people who believe that they've tried everything. I've met people who have given up, but I don't even know how you would diagnose what exactly is the definition of non-compliance. And I think that it's more about diabetes distress than non-compliance. I don't think it's true that people don't care. I think sometimes somebody cares so much that they can't tolerate looking at it anymore. And if that's you, I don't need you to fix your entire everything with diabetes today. I need you to do something much smaller. Answer the phone, answer the text, make the appointment.
Yeah.
Tell somebody my diabetes has gotten away from me and I need help. And that's enough for today. And
do one thing that diabetes hates right now. Just one.
And I know someone that just today has done just this. And I'm very proud of them. Okay, so I guess we'll continue. So let's say that you're like, all right, I've made that text. I've made that phone call. That was too sad to end on. So I have to just keep going. So where do you begin? And it's not with losing 50 pounds. Great, if you can do that, go around and tell people how to do that safely and make sure that none of what you lost of that 50 pounds was muscle or bone mass or it was just visceral fat. Not with going out and running a marathon or training for a 5K if you're not even walking right now. Not by throwing everything in your kitchen away, and definitely not by punishing yourself. Some sort of self-flagellation is not helpful. First, get safe. That is the first thing. If your glucose is severely elevated, particularly if you're sick or having symptoms of a hyperglycemic emergency, get medical guidance. Take medications as prescribed. Monitor your glucose according to the plan your healthcare team gave you. If you're supposed to monitor ketones during illness or severe high blood sugar, know how to do that and when. I think oftentimes people are told to monitor ketones and then never explain what that means or what that looks like or how to do that. Make sure you're drinking appropriate fluids. Oftentimes when people go into diabetic ketoacidosis, I used to work in a hospital and I would talk to them and they're like, I was just so thirsty all the time. So I just kept downing the orange juice. And it's like, the worst thing you could do. Yes. Or drinking a bunch of Mountain Dew. I've literally heard people say these things. And know when your symptoms require urgent or emergency care. That is step one, not remission, safety. And then stabilize. So it's not the time for some sort of desperation diet. You don't need to announce, tomorrow I'm never eating carbs again. Throw everything in and go on this big binge the night before because tomorrow, no carbs. You don't need a 7-day fast or cleanse. You don't need to exercise 2 hours because you're angry at yourself or to get the blood sugar down. You want some predictability back. Regular meals, medication, fluids, sleep, monitoring your glucose.
Regular movement.
Movement appropriate for your current medical situation. We're trying to turn that chaos into just some sort of semblance of rhythm or habits or patterns. Because rhythm gives us something to build from, because then we rebuild. So maybe your first goal is walking 2 minutes after dinner, and then 5, and then 10 minutes. Maybe it's getting groceries into your house. Maybe it's preparing breakfast instead of skipping until you're just starving and hunger monster comes out at noon. Maybe it's making the follow-up appointment with your healthcare provider or physical therapist or whatever that looks like. Maybe it's taking medication consistently for just 1 week. Just get it done 1 week. Maybe it's getting back into diabetes education, getting back with a diabetes educator. And eventually, yes, we can talk about weight if that is relevant to you. We can talk about resistance training, fiber, meal composition, sleep, stress, cardiorespiratory fitness, visceral and ectopic fat. All the things we talk about in the podcast that can improve insulin sensitivity and support remission. But we are not rebuilding your entire life this Monday when the podcast airs. We're just establishing the next foothold and the next one and the next one after that. So we often talk about you are your own healthcare provider, and I don't mean never see the doctor when I say that. So probably maybe we might change our little catchphrase to take responsibility for your health.
You're your healthcare provider the other 89 days out of 90 days that you are not in direct correspondence with your clinician.
That is a much better framing of that for sure, because personal agency matters very much. And I think there's a more complete way to understand responsibility, because it doesn't mean I control every outcome, because you don't. Nobody does. Taking responsibility means when circumstances change, I respond to that change. And sometimes responsibility looks like getting up at 6 a.m. and exercising. Sometimes it looks like ordering the vegetables and not letting them go into that bin to die.
Oh, no.
Sometimes it looks like losing a little bit of weight. So, and by weight, I'm talking about specifically trying to keep muscle while you lose fat. And that's very strategic. Sometimes taking responsibility looks like taking the insulin you desperately hoped you would never need again. Sometimes it means telling your doctor, I'm not doing so great. Sometimes it means telling somebody I need help. Sometimes it means recognizing that something in your living environment, your job, your finances, or your relationship is affecting your health. And sometimes taking responsibility for yourself means letting somebody else carry just a little bit of the load, because that's not weakness. It's not giving up. That is responding to what is your reality. And I want to say one more thing here, because it's an evolution of how I talk about this. And so back to that, you are your own healthcare provider. You are the most important member of your healthcare team.
Ooh, I like that one.
Yay. I thought you might. And today, part of your job might be letting the rest of the team do their job. So reality is always where good diabetes care has to begin. So maybe you're listening to me right now, remembering a version of yourself who seemed to have this figured out. You exercised, you ate differently, your glucose came down, you lost weight, you got medications reduced, and maybe you achieved remission from type 2 diabetes. And you're looking at your life today thinking, how did I get back here? I don't know your whole story. Nobody does. But I know I don't want you to hide your glucose meter because you don't want to know what the number is. I don't want you to avoid your doctor because you're afraid to go back or afraid they're going to scold you or what they're going to say to you. Don't refuse medication today because you hope that you never need it again. You swore to yourself you'd never go back on that again. Do not wait until you're dangerously sick because you think that you can handle this, that you can do it yourself. And don't decide that because you can't fix everything today, there's no point in doing anything. I always think of the Grinch, like, I'm just not going, like it's not often that you can tackle everything in one day. Just come back anyway, make the call. The people that are trying to help you, check your blood sugar. You might be angry. Okay, come back anyway. You might feel disgusted at the weight you've gained. Okay, come back anyway. You've got to take care of yourself. It might be the highest your A1C's ever been. Okay, come back anyway. Yeah. Come take care of it. You haven't seen your doctor in 3 years. You have to establish as a new patient, see somebody else first before you get the doctor you really love. Okay, come back anyway. Get back on track. You don't need any kind of explanation you don't have to make up some kind of story about why you're back and what happened. Just say, I'm ready for some help. The past doesn't matter at that point. It is, I'm ready to get back on track. Help me get this under control again, because the past is done. Yeah. It's about how do you move forward from that point, because the previous success wasn't proof that you're a good person, and what's happening now isn't some kind of proof that you're a bad person. I
would say the previous success is proof that you can kick this thing's butt, and that it's apparently time to put on the butt kicking boots again.
Yes,
and get back to it.
Exactly. It's physiology, and physiology responds to environment, medication, movement, nutrition, all the things that we mentioned before. And even sometimes circumstances that we've never chosen, you still have to look at that physiology and how can I change it for the better? Because understanding that gives you a better place from which to use the physiology. And you've done hard things before, and today you get to prove that you can do it all again.
Yeah. All right. Well, this has been yet another episode of the Diabetes Podcast. Thanks for listening to the Diabetes Podcast. If you like what you heard, please click that follow or subscribe button, and don't forget to check out roadmap.thediabetespodcast.com for that free pre-diabetes and type 2 diabetes remission roadmap. Until next time, take courage. You can do this, and we can help.